Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and a very good morning to all the participants. It is indeed an honor and a pleasure to be a part of this great RheumaCon. My apologies for not being present there physically. It was because of some unavoidable circumstances in my family. So the topic of my talk today is Etanercept, Years of Practical Evidence. And before I begin, I would like to disclose that the talk has been sponsored by Pfizer. These are the learning objectives of my talk. I'm going to give you a brief overview of the drug, its structure, and different indications for the use of this drug. I'll also be going through the possible adverse events that can happen when a person is being treated with Etanercept. This would be followed by some real-world data that has been gathered from different registries. And in the end, I'll be discussing a couple of cases from my clinical experience where I've used Etanercept for the management of ankylosing spondylitis. So before starting formally, let us recall our knowledge of immunology. You all know that TNF-alpha molecules are one of the most potent mediators of inflammation, and it has been implicated in the pathogenesis of several rheumatic diseases, including rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, etc. So it is only logical that any drug that can counter the effect of TNF-alpha molecules would benefit the patient. So keeping this in mind, let's now go through the structure of Etanercept. So this was the first ever biologic drug to get FDA approval for the management of SPA. It is basically a dimeric fusion protein consisting of two TNF receptor molecules. So these are the TNF receptor molecules, these blue structures here, and these are then connected to the FC portion of IgG1 antibodies with the help of these protein bridges. So the resultant molecule works as a decoy receptor to which the circulating TNF-alpha molecules bind, and then they get neutralized, and hence the process of inflammation comes to a halt. This is just a diagrammatic representation of whatever I've just mentioned. These are the circulating TNF-alpha molecules which get attached to the Etanercept molecule, and after this binding, they get neutralized and their function comes to an end. So this is the timeline of FDA approval for Etanercept. It first got approval for the management of rheumatoid arthritis in the year 1998. And this was followed a couple of months later by approval for management of GIA. It wasn't until July 2003 that it got approval for the management of ankylosing spondylitis. So this is the landmark trial on Etanercept, after which this drug received FDA approval for the management of ankylosing spondylitis. The principal investigators were Dr. John C. Davis and Dr. Vander Heide. There were a total of 277 patients in this trial. 139 of them were being treated with placebo and 138 of them were started on Etanercept. The dose of Etanercept that was used was 25 milligrams twice a day, and it was given to the patients for 24 weeks. At the end of 12 weeks, it was noticed that 59% of the patients in Etanercept group and 28% of the patients in the placebo group achieved ASAS-20 remission. And when it was carried out for another 12 weeks, it was noted that 57% of the patients in the Etanercept group were still maintaining ASAS-20 response, whereas only 22% of the patients in the placebo group could do so. So these are a couple of indications, FDA-approved indications for which we can use Etanercept. In adult population, we can use it for the management of rheumatoid arthritis, axial spondyloarthritis, psoriatic arthritis, plaque psoriasis, etc. And as far as pediatric population is concerned, we can use it for the management of GIA in children who are 2 years of or older in age. It can also be used for the management of psoriatic GIA, again in children who are 2 years or older. And it can also be used for the management of plaque psoriasis. So as far as adverse effects are concerned, the list is really long, but fortunately the overall incidence is not too high. The first and the foremost are the cutaneous reactions, and of these, injection site reactions are the most common ones. About 5% of the patients can present with injection site reactions, and this includes itching at the site of injection, erythema formation at the site of injection, or bruising. And sometimes the patients can even have a generalized allergic reaction, and sometimes they can even present with fixed drug eruption. This is followed by incidence of by development of serious infections, and FDA has actually given a black box warning. So there is a chance that once the patients become immunocompromised, they can develop fungal infections, bacterial infections, and even different opportunistic infections. And then there's also risk of reactivation of tuberculosis. This is actually very pertinent to people living in subcontinent, because we know that our area is endemic for tuberculosis. So it is mandatory that anybody who's going to be started on Etanercept must be screened for the presence of latent tuberculosis. And this can be done by having a look at their chest X-ray, by performing a Monto test, and also going for IGRA testing. Then there's also a chance of reactivation of hepatitis B infection. And again, it is advocated that patients be screened for latent Hep B infection by looking for their hepatitis B core antibodies. And if they're found to be positive, then they should be asked to have their hepatitis B DNA PCRs done. And if the PCR is positive, then they should be given prophylactic, they should be given treatment for hepatitis B infection. And if the PCR is negative, then it's mandatory that you keep on repeating the PCR every 3 to 6 months, just to make sure that the virus is not getting reactivation. So next, there is also a concern that patients can develop worsening or a worsening of existing heart failure, or they can also develop new onset of heart failure. So it is suggested that patients should have a baseline echo done just to assess their cardiac function. And patients who have NYHA class 3 or 4 heart failure should not be treated with Etanercept. Hepatotoxicity is also encountered sometimes in patients who are taking Etanercept. It can simply be a case of transaminitis precipitated by the use of Etanercept, or there have been cases where autoimmune hepatitis, the patient has developed autoimmune hepatitis. So whatever the case may be, stopping the drug helps in this helps the patients. And next, we can also encounter hematological side effects, but fortunately the incidence is really low. It is less than 0.1%. So patients can present with pancytopenia, or very rarely they can also develop aplastic anemia. We have also seen over the years that patients can develop a lupus-like disease after getting treatment with Etanercept. So anybody who becomes ANA positive, develops characteristic rash of lupus, presents with hematological or any other manifestations of the disease, must be checked for the presence of anti-dsDNA antibodies. Fortunately, as soon as Etanercept is stopped, this manifestation also starts to abate. Then there's another black box warning regarding the use of Etanercept, and that is the development of malignant lymphomas and solid organ tumors, and this is especially true for the pediatric group. However, the data is still conflicting, and some authorities believe that it is not because of Etanercept that they develop malignant malignancies. It is perhaps because of the primary disease that they suffer from, or because of the concomitant use of other immunosuppressant drugs like methotrexate or azathioprine. Whatever the case may be, we should always be on the lookout for this particular adverse effect. Then patients have also been seen to develop antibodies against the Etanercept molecule. These antibodies are usually non-neutralizing, as opposed to the antibody formation against other TNF-alpha drugs like all the MABs that are there. So if a patient is not responding to the Etanercept treatment anymore, then it is worth checking for the antibody development. Lastly, there's also a concern that patients can develop certain neurological complications. Unfortunately, again, the incidence of these side effects is very low. It is less than 0.1%. So patients can develop demyelinating disease, Sometimes patients have also presented with optic neuritis, transverse myelitis, or even multiple sclerosis. So with this, I come to the next part of my presentation where I'll be sharing real-world data regarding efficacy of Etanercept. So it has been shown to be effective in reducing the signs and symptoms of ankylosing spondylitis, including pain, stiffness, and inflammation. Many clinical trials and observational studies have demonstrated improvements in disease activity and physical function after getting treatment with Etanercept. So one such study is basically the Adequate study, which is a German prospective non-interventional study, which was done to evaluate the proportion of patients who respond to treatment with Etanercept. It had different limbs. For example, patients who had rheumatoid arthritis, patients who had psoriatic arthritis, and ankylosing spondylitis, all of them were evaluated in different limbs. So I'll be focusing only on the results only from the ankylosing spondylitis limb. So initially, 333 patients entered the study, and 28 of them were excluded because they did not fulfill the entry criteria. 305 patients were then included in the study, and however, only 182 patients could complete the study. The rest of them continued, were dropouts because of various reasons, like insufficient effectiveness of the drug because of presence of different adverse effects or due to any other reason. So the patients who completed the study, it was noted that at the end of 24 weeks, 19%, almost 19% of the patients had achieved remission, whereas at the end of 52 weeks, 23% of the patients had achieved remission. And as far as low disease activity is concerned, 45% of the patients achieved low disease activity state at the end of 24 weeks, and 45% of the patients achieved low disease activity state at the end of 52 weeks. And these statistics are actually quite encouraging. And as far as maintained responses are concerned, it was shown that patients who had achieved remission maintained this response. 56%, almost 57% of these patients maintained this response at week 24. And also patients who had achieved low disease activity, about 65% of them maintained this low disease activity state at the end of 24 weeks. It was also noted that there was a decrease in the usage of steroids by the patients, and overall there was also a decrease in the dose of steroids that were being used, and this also indirectly meant that the drug was working nicely, and the requirement for steroids started declining after some period of time. As far as adverse effects are concerned, the major treatment emergent adverse effects were drug ineffectiveness, which was noted in 10% of the patients. Then 7% of the patients developed nasopharyngitis. None of the patients had to be hospitalized for that. 2.6% of the patients experienced aggravation of their existing condition or developed injection site erythema or any other injection site reaction. And around 1% of around same percentage of the patients developed hepatobiliary disorders. As far as treatment emergent serious adverse effects were concerned, they were seen in 11% of the patients. Of these, cardiac disorders, intervertebral disc protrusion, hepatobiliary disorders, and GI disorders were most notable ones. So in conclusion, these findings confirmed the effectiveness and safety of Etanercept in routine clinical practice and highlighted potential benefits of continuing Etanercept treatment in patients who have not reached their treatment goals beyond 12 weeks. And additional benefits included improvement in patient-reported outcomes and reduction of concomitant glucocorticoid usage. So I think we all need a breather after this heavy discussion. Let's take a moment out and marvel at the beauty of this mighty mountain, K2. This picture has been taken from Concordia, which is basically the base camp of K2, and it's one of the most wonderful sights in this world. So moving on, I'll now be discussing some real-world data regarding safety of etanercept in ankylosing spondylitis. So here, generally, it has been noticed over the years, that etanercept is a very well-tolerated drug in patients with ankylosing spondylitis. Common adverse events associated with etanercept treatment include injection site reactions and upper respiratory tract infections, as we have already seen in the previous study. And serious adverse events such as infections and malignancies have been reported, although the overall incidence is pretty low, as has already been discussed. So in this regard, I'll be sharing the results of ESTER trial. This study was published in 2021, and patients with ankylosing spondylitis who were being treated with etanercept were followed for a period of 10 years, and then the results were published. So there were a total of 76 patients who were enrolled in the study. 40 of them were started on etanercept, whereas 36 of them were started on sulfasalazine. And overall, 66% of the patients completed the study for a period of 10 years. These are the different disease and functional status assessment parameters that were assessed. This one is PASTI. This dotted line here represents PASFI score. This interrupted line here is for ASTAS CRP, and this line here is for PASMI scores. And all of these scores were assessed at week 24, and all of them showed a rapid decline. And this was then sustained over a period of next 9.5 years. So this was quite encouraging. So as far as details of this trial are concerned, we first have a look at the PASTI score. We see that the baseline PASTI score was quite high for both the radiographic and non-radiographic SPA patients. It was 5 and 6.2 respectively, and both these groups showed significant decline in their PASTI scores at week 24. It was found to be 2.4 for the radiographic SPA patients and 3.2 for the non-radiographic SPA patients. And then this was sustained over the next 9 to 9.5 years time period till the end of 10 years, when it was still 1.9 and 1.4 respectively. Similar was the case with ASTAS score. At the baseline, it was quite high, but at 24 weeks, it had declined to 1.5 for the radiographic SPA patients and 1.7 for the non-radiographic SPA patients. And then this response was sustained over the next 9 years. Till at the end of 10 years, it was 1.2 for the radiographic SPA patients and 0.9 for the non-radiographic SPA patients. Same was the case with CRP. Initially, we can see that patients had high CRPs, but by week 24, the CRP levels had declined, and then this was sustained over the next 9.5 years. So to conclude, it was noted that during the 10 years follow-up, a total of 39 serious adverse events in 20 patients were observed, and 30 of these actually required hospitalization for diagnostic workups. But when you think of it, that it was a long-term study spanning 10 years, this is not a very high number. So among all these serious adverse events, only 7 were regarded as possibly or probably treatment-related, and 3 resulted in discontinuation, and only 3 resulted in discontinuation of etanercept. There were fortunately no cases of opportunistic infection, tuberculosis, or solid organ tumors. So in conclusion, etanercept showed long-term clinical response and also demonstrated consistent safety when administered in patients with axial SPA over a period of 10 years. And this was actually quite encouraging. And lastly, I would also like to share real-world data regarding NSAID sparing effect of etanercept in patients with angst. This SPAR study was carried out in France, and I'll briefly share the results with you. In this trial, treatment with etanercept was associated with clinically relevant NSAID sparing effect of the drug, which coincided with significant improvement in conventional clinical outcomes. And this is also very important because we know that continued use of etanercept of NSAIDs can result in variable side effects. So the sooner the patients get off NSAIDs, the better it is for them. And they can do so only if the drug is effective. And here in the graph, we can see that there was quite a significant number of patients who actually attained an ASAS NSAID score of 0, which means that they were not taking NSAIDs at all. So in summary, we have learned that Etanercept is very effective in reducing the disease activity in patients with SPA. Also, it is very safe to use. The incidence of adverse effects is not too high. And we have seen that over a period of time, patients tend to show good adherence to Etanercept. And also, it has got an NSAID sparing effect, which is very, very beneficial for the patients. So I think we needed another breather, and this is from one of my favorite most lakes. This is Upper Kachura Lake in Skardu Valley, and it's a beautiful place to visit. Those of you who have not been here, I think must go in the summers and explore the area. It's a beautiful area. So this brings me to the last part of my presentation, where I'll be discussing a couple of patients from my own clinic. The first case is that of a 36-year-old male patient who had a long-standing history of left hip pain and backache. The history dated back 10 years. He hailed from Ahmedabad district and was primarily being treated by the GPs and Hakims there. He had severe limitation of activity when he first presented to us, and he was walking with the help of crutches. On evaluation, he was found to have advanced ankylosing spondylitis along with damaged left hip joint, and he was also found to have avascular necrosis of the right hip. His disease activity was very high, with a PASTI score of 6.1 and ASTAS CRP score of 3.58. And since the disease had been present there for more than 10 years, we wanted to make sure that he still had active disease. So we went for an MR scan, and it showed that he still had active metasignals both at the SI joints and in the lumbar spine. So he was started on weekly Etanercept dose of 50 milligrams subcutaneous injection, and he showed marked improvement at 3 months of treatment. Once his disease was stable, he also went for bilateral hip replacement surgery. Currently, he has a very well-controlled disease with a PASTI score of 1.4 and ASTAS CRP score of 0.9. And he's now taking Etanercept every 2 weeks with occasional use of NSAIDs for pain relief. And I must mention here that this dose is per my clinical experience. For approved dosage, please refer to Etanercept label. This is not the FDA-approved dosage of Etanercept. And this gentleman is now quite happy and satisfied with his life and is working as a supervisor in a timber company. So the next case is of a 22 years old male who was brought to our clinic by his father. Now, I remember very well when they arrived in our clinic, they were both crying. The boy was crying because he was in a lot of pain, and his father was crying because he thought that his son had become disabled for life now. So on probing, we found that he had complaints of left hip pain and inflammatory backache for the last 2 years. He went to local doctors and Hakims for treatment and was given painkillers and steroids. And he was also told to get a disability certificate because people thought that he wouldn't be able to get up and go to university again. And they thought that it would be better if he got a disability certificate so that he could qualify for some sort of help from the government. So on evaluation, he was found to have active sacroiliitis on MRI and a damaged left hip joint along with effusion in his left knee. He had high disease activity scores. ASTAS CRP score was 4.2 and PASTI score was 5.85. After preliminary workup and ruling out tuberculosis and hepatitis B infections, we started him on Etanercept 50 milligrams sub-Q every week. Miraculously, he started showing improvement after third injection. And after 3 months of treatment, he had marked improvement in his disease activity scores and was able to without support. His PASTI at the end of 3 months was 3.85 and ASTAS had reduced to 1.27. What was more amazing was the fact that he was now walking without support, and he resumed his studies and completed it eventually. and he's now working as an accountant. His dosing interval, once he had achieved remission, his dosing interval was increased to 14 days. But this is again as per my own clinical experience, and this is not the FDA approved dosage for dosage of etanercept for the management of ankylosing spondylitis. So he has been advised to have his surgery done for the avian of avian of hip as well, to help him with the discomfort that he's currently having despite the disease being in remission. So we consider this our success story. Case number 3 is of a 23-year-old boy who was initially labeled as oligoarticular type of GIA since he developed the symptoms when he was 15 years of age. Now he hails from Mardan, and he was treated there by different orthopedic surgeons and also pediatrician. And he was started on methotrexate 10 milligrams per week with no use. Then he was started on sulfasalazine 1 gram a day, but again, he did not show any improvement. And along with these, he was also taking variable doses of steroids. So he presented to us with complaints of swelling and tenderness of left knee joint and right elbow joint. And he also gave a history of inflammatory backache, which was causing considerable limitation of his daily activities. He was found to have a positive Faber test bilaterally, and imaging confirmed presence of bilateral sacroiliitis. His inflammatory markers were skyrocketing with a CRP level of 90 and ESR of 140. Keeping in mind all of these features, he was diagnosed as having enthesitis-related GIA, which is the juvenile counterpart of ankylosing spondylitis. He was initiated on Etanercept 50 milligrams once weekly after ruling out latent tuberculosis and chronic Hep B infections. He had a BASTI of 6.5 at baseline before he was started on Etanercept, and ASTA CRP score of 4.8. However, both of these scores had reduced to 3.2 and 2.5 respectively after 2 months of treatment. So currently he has a BASTI score of 2.8 and ASTA CRP is 1.2, and this shows that he's now in remission. He's working as a software engineer somewhere in Mardan and is quite contented with his life. So with this, I say thank you to you, and I hope you found this interesting as well as useful. Thank you very much for your patient listening.